Good morning, Dr. France. It's my pleasure to have you here at UD Health San Antonio, and it's an honor to have you present at our opioid symposium here today. And we know you do a lot of work on opioid abuse, overdose, and dependence, to be specific. So tell me, what is the contribution of different opioids, including prescription opioids, heroin, fentanyl, to the opioid epidemic?
Sure. Well, the opioid epidemic, in fact, has its genesis many years ago. It's been going on probably for 20 years, but with the mushrooming of overdose deaths in the last 5 to 7 years, it's come into the public spotlight. Clearly, the beginning of it, quite honestly, was the overprescription and misprescription of drugs that were used for the wrong thing, and they were used too long and at too large a doses, and they created a population of people that became dependent on opioids. With that growth in prescription opioids came a black market, which increased the price of those pills, and heroin distribution followed right behind it and allowed people to buy inexpensive, widely available heroin. So that was sort of the second phase. The first phase was prescription opioids. The second phase was the availability of heroin. People who never dreamed they would put a needle in their arm but had developed a habit with a pill, it now could buy much cheaper heroin to keep themselves from going into withdrawal. The third phase of it, tragically, is the advent of fentanyl derivatives, which have come on the scene just in the last few years, though fentanyl was discovered many, many years ago. There are thousands of fentanyl drugs, literally, and the problem with them, one of the problems with them, is they're very easy to make. Basic chemists can whip up lots of fentanyl derivatives without much effort. They're exceptionally potent. Some of them are 1,000 or 10,000 times more potent than heroin. So unsuspecting individuals who think they're taking heroin or some other opioid and take a fentanyl derivative succumb to the respiratory depressant effect. So it's really been three phases: prescription opioids followed by heroin, and now really a combination of all three with fentanyl added to the mix.
And then that's how they've been, but the most contribution has been, in your opinion, by which of these?
I don't think we can lay guilt on any one of them. It has been a sequential process. Clearly, the overprescription of drugs got us into this mess in the first place.
Okay.
I mean, if we look at people who have misused opioids, the large number of them have gotten them as a prescription initially. Most people get a prescription opioid from somebody they know. They don't buy it on the street. The medical profession has some responsibility to share, but they have recognized that, and they clearly are cutting back, and there is legislation which is cutting back to restrict access to those drugs and to use them for the proper thing.
So what is the difference between opioid abuse and opioid dependence?
Sure. Well, opioid dependence, as we defined it in science, is the development of a physical dependence. So it's an adaptation of the body to the repeated stimulation of the brain with drugs. And dependence is often a consequence of abuse, but not necessarily. People will abuse opioids under conditions where they don't become physically dependent. The converse of that is some people take opioids for legitimate medicinal purposes and become physically dependent. People, for example, suffering from chronic cancer, pain, or other sorts of disorders where chronic opioids are warranted, may become physically dependent. That is to say, they need the drug in order to function normally. Opioid abuse or opioid misuse is having an obsession for the drugs, even in the face of knowing that they are adversely affecting your personal well-being, socially, physically, and otherwise. So it's the inappropriate use of opioids.
So do you think a person could be psychologically dependent on opioids and not physically dependent?
That's a complicated one. Clearly, we do differentiate physiological versus psychological dependence. The physiological being defined, as I indicated earlier, by just stopping taking drug. And if you see a manifestation of physical signs, usually a sympathetic arousal, you feel sick, nauseous, flu-like, then that would be characterized as physical dependence. But yes, psychological dependence does occur by definition, because people sometimes abuse drugs. They use them inappropriately under conditions where they don't develop physical dependence. That's less common with opioids because the adaptation to opioids is fairly profound and fairly quick. But it is very true with other sorts of drugs, stimulant drugs, cocaine, amphetamine, etc., where people maybe don't take them every day, but they take them periodically. They feel the need, the urge, craving, if you will, to take those drugs, but there's no clear evidence of physical dependence.
So what medications are used to treat opioid abuse and overdose, and do you think they are effective?
The answer to the second part is that yes, they are very effective, though they're not unanimously effective. 3 general drugs that are used to treat opioid misuse. They're called methadone, buprenorphine, and naltrexone, and they come in various formulations. The good news is they work. The bad news is they don't work in everybody, and they've been around forever. Methadone was first available 70 years ago, naltrexone 50 years ago, and buprenorphine maybe 30 years ago. Methadone essentially replaces the abused opioid, so people who are taking hydrocodone, heroin, or any other sort of opioid can be transitioned to methadone without any adverse consequences and maintained on the drug. So that's one side of a drug that substitutes for the opioid. The other side is a drug that blocks the effects of the opioids, and that's naltrexone. It binds to the same places in the brain that heroin binds to, but it blocks the effects of heroin. So it doesn't provide any satisfaction the way that methadone does, but it will block the abuse-related effects of heroin. Intermediate to those two, to methadone and naltrexone, is a drug called buprenorphine, which, for reasons that are more complicated than this discussion, shares some effects with both methadone and naltrexone. It can substitute for some of the aspects of opioids and therefore make people feel not so bad and not go into withdrawal, but it also blocks effects of opioids. It has a long duration of action. It's relatively safe. So those are the three that are used, and they're used under different kinds of conditions. If somebody is currently taking an opioid, you can put them on methadone. You can't put them on naltrexone because it will precipitate withdrawal. There's actually a fourth drug approved for treating opioid misuse, and it's lofexidine. Many people will know the drug clonidine, which is an antihypertensive drug, so is lofexidine. And these drugs are used to suppress the withdrawal signs that emerge if people stop taking opioids. So that's on the abuse side. On the overdose side, we also have a very good drug. It's called naloxone. It sounds like naltrexone. They're close cousins. Pharmacologically, they're very similar drugs. And naloxone is, again, a drug that blocks the receptors in the brain where heroin acts. So if people have suffered from an overdose from an opioid, naloxone rapidly reverses it. That's the good news. The less good news is that naloxone has a very short duration of action, and most of the drugs that people abuse have a longer duration of action. A case, for example, of something like OxyContin extended release, it's an 8-hour duration of action. Naloxone lasts 30 to 40 minutes. So in situations where people have overdosed on very large doses of drugs, they may well require repeated rescues with multiple doses of naloxone, or in an emergency department setting, a naloxone drip in order to keep them safe.
Do you feel like these medications have any side effects that are, worse than the withdrawal that these patients might experience?
Well, there are really not any adverse effects of either naloxone or naltrexone, the antagonists. The compliance with these drugs is not terrific. Remember, these are people who have a long history of taking drugs, and to put them in a situation where they're not only not taking drugs, but if they attempt to take drugs, they're not going to get any high from it, reduces compliance. Methadone and buprenorphine, both of them have effects, as I said, that are in common with heroin, so they both have some possibility of being abused and diverted for abuse. Although methadone is used to treat opioid abuse, these days on average, 3,000 to 4,000 people per year die from a methadone overdose. So you have to be very careful with it. And with both methadone and buprenorphine, any opioid, one has to be careful about having them in combination with other drugs, particularly with CNS depressant drugs like benzodiazepines, barbiturates, etc. So while they're very good at maintaining people in a condition where they don't have to seek out use of opioids, individuals have to be careful because co-administration of those drugs with alcohol or benzodiazepines can be lethal.
So what is limiting the use and effectiveness of the available medications for treating opioid use disorder?
Well, I think probably several things. One is stigma. There still is a stigma associated with substance use disorders. People fail to recognize that it's a serious medical condition, that it needs treatment, not unlike diabetes, and until we recognize that, it's going to be difficult to get medications distributed. I think secondly is access, having enough people in a position where they can distribute the drugs to the people who really need it. Remember, the opioid crisis really took hold in this country in rural America, in southern Ohio and West Virginia and Kentucky, and places where people don't even see a physician in a year, much less an addiction psychiatrist. So how do you get drugs to these people, particularly drugs that may be onerous to take? Methadone is a solution that people drink, and they have to go to a special clinic and drink it each day. That's simply not feasible in rural America. So I think the stigma associated with it, and I think the access issue, I think we really have to get drugs out to people. So when folks come into emergency departments overdosed on an opioid, they're not just rescued with naloxone, but they're rescued and put into a treatment program and perhaps get on a buprenorphine regimen whereby they can reduce their subsequent drug taking.
All right. So are there any new medications for treating opioid use disorder and abuse?
There are lots of them in the pipeline. The pharmaceutical industry has largely been asleep on substance use disorders over the years, with the exception of nicotine, smoking cessation. Pharma, $2 to $3 billion, 15 years to develop a drug. The number of patients that you can put your drug into in terms of substance abuse is a small patient population. And so there's always this hesitancy of big pharma of getting into this business. But they have now come to the fore, I think, appreciating not only that there's a problem, but frankly, there's money to be made. So lots of companies are working on it, and they're working on it in two fronts. One front is to develop pain medications that are not opioids, or to enhance the effects of opioids so that smaller doses can be used. And there are lots of things going on in that venue. The other side of the coin is the development of new medications to treat substance use disorders. In fact, there's a group of investigators that I'm affiliated with here at the Health Science Center that's developing a new drug that can sort of be thought of as a super naloxone. It's a drug that reverses the respiratory depressant effects of opioids, but provides sustained protection from subsequent overdose for up to a week after a single injection. And it looks to be very, very promising because a fairly significant number of people who were rescued once with naloxone need to be rescued a second time because of their own bad choices in life. So yes, there's a lot going on.
All right. How many opioid doses taken during acute pain episodes do you think would lead to a risk of opioid abuse or dependence?
Well, it varies hugely depending upon the drug that we're talking about. We talk about opioids generally in terms of milligrams of morphine equivalents. And if the milligrams of morphine equivalents get to 30 to 50 milligrams, there can clearly be trouble. And at equivalents of more than 50 morphine milligram equivalents, the risk of overdose doubles. So it goes up very, very dramatically.
Okay.
So it's both the acute effects of opioids we have to worry about, but also the long-term continued use of them, because that's how the physical dependence develops. I mean, short-term use, a week, 10 days of an opioid under managed conditions at the appropriate dose is quite reasonable. But 2 weeks and beyond in physical dependence can clearly begin to develop in a clinically relevant way.
That's a pretty short time to develop.
It's a very short time.
Yes. Yeah. Well, thank you so much for answering those questions. The session was great, and thank you for being here.
Thank you for the opportunity.